everyone. Welcome to the Royal Brompton Virtual Grand Rounds again this morning. It's an absolute pleasure to introduce Patrick Forde, Professor Forde, who is kindly going to speak to us about expanding the checkpoint inhibitor landscape in lung cancer. Professor Forde is very well known, obviously, amongst the community and is currently Professor of Immuno-Oncology at Trinity College Dublin, previously affiliated with Johns Hopkins. I will hand over to him to give his talk. As always, we will have a 15-minute presentation followed by 15 minutes of questions. Please do place questions in the chat, in the Q&A, so that we can field those at the end of the talk. Handing over to you, Professor Forde. Thank you very much for joining us.
Great, and thanks very much for the invitation. I'm just going to share my slides. So the title here is relatively broad, so I thought I would concentrate more on the earlier stage disease landscape, and hopefully go through some of the recent data and some of the clinical questions which arise when we see patients with stage 2 or 3 lung cancer. These are my disclosures. So there's been a lot of advances with immunotherapy. So when I first started working in this area about 2010, the median survival for patients with lung cancer was probably in the range of 8 to 12 months, with less than 3% of patients still being alive at 5 years. However, back in 2011, one of my colleagues at Hopkins, Julie Bramer, published a paper on the use of single-agent anti-PD-1 for patients with pre-treated lung cancer. And you'll see that in the middle of the screen here in the New England Journal. So if we fast forward 15 years from that, PD-1 immunotherapy, either on its own or in combination with chemo, are alive and still in remission at 5 years. But it's not enough, obviously, and it varies. So if you have PD-L1 high disease, and that number is probably more like 20%, PD-L1 negative, it's more like 5 to 7%. But this has been recognized as a breakthrough. You'll see here the Science cover a few years ago, and Jim Allison, who discovered the first checkpoint, essentially was awarded the Nobel Prize now about 6 years ago. However, they had data for the first 10 years, really, of checkpoint inhibitor development was in advanced disease. And earlier stage disease was really neglected somewhat. We were slow to transition these drugs through the stages from stage 4. We did have an approval for stage 3 disease in 2017 in the consolidation setting after chemoradiation. But the surgical setting was still really, we were restricted to surgery and or systemic chemotherapy. And this is, I think, the 7th edition of staging, the last one, which kind of didn't include any patients treated with immunotherapy. And if you look here, the survival by clinical stage was only 60% for patients with stage 2A, to only a third of patients with stage 3s. And this makes up quite a significant proportion of patients. If you look at the numbers, probably about 600 to 700,000 patients worldwide who have potentially curable surgically resectable lung cancer. We did a small study starting back in 2013 and running through the end of 2014, where patients essentially had a window of opportunity prior to surgery for stage 1 to 3 lung cancer and got 2 doses of immunotherapy. And we saw, somewhat surprisingly, that 45% of them, so 9 out of the 21 patients, had a major pathological response, and their tumors shrank quite significantly. We now have 5-year follow-up from this initial cohort, and you'll see here among the patients in blue who had a major pathological response, very few of those have had a relapse of cancer, and nobody has died from cancer. However, those patients who didn't have a major pathological response to immunotherapy as a single agent, several have had a recurrence of disease and or death from cancer. So the assumption from this, I guess the corollary is that these 2 doses of immune therapy were making a difference for these patients. Fast forward to more recently, and this is the current landscape, at least in the US, which tends to approve things very quickly. We have a neoadjuvant approval, checkmate 816, 3 cycles of chemo plus nivolumab, followed by surgery. with no mandated postoperative treatment. We've two adjuvant approvals. So the IMpower010, which is chemotherapy followed by atezolizumab in the adjuvant setting. But that approval is restricted in Europe to the PD-L1 high group and in the US to the PD-L1 positive group. There's also Keynote 091, which was chemo followed by pembrolizumab. The challenge with these two studies is neither of them have shown an overall survival benefit. And secondly, the data kind of internally has a little bit of, it's been somewhat inconsistent, particularly with Keynote 091, where the PD-L1 negative group did better than the PD-L1 high group. So the adoption has been relatively modest among medical oncologists, at least. Then you have 3 perioperative regimens, which are now approved. One of which has shown an overall survival benefit, the Keynote 671. And this is pembro chemo for 4 cycles, followed by up to 10 months of adjuvant pembrolizumab. So we have 2 studies with an overall survival benefit, and we have 4 studies with a disease-free or event-free survival benefit. The important thing to keep in mind is when we're seeing patients in the MDT or tumor board, at present, all of these studies require the patients to be suitable for chemo. So patients still have to have levels of kidney function, levels of performance status, which permits them to tolerate systemic chemotherapy. And this is kind of another graphical representation of where we were in 2018. It was a pretty low-key landscape for resectable lung cancer. Now we have all these different options potentially. We may have another one soon in the adjuvant setting for patients with RET fusions, about 1% of lung cancers. There was a press release about a month ago suggesting that the adjuvant phase 3 trial in that setting was positive. So we may see more and more patients triaging towards the targeted therapy, but those patients without targetable alterations essentially go down one of these different pathways here in the middle. To talk a little bit about some of these studies, so Checkmate 816 was a relatively simple study. It was the first one to start in the neoadjuvant setting for quite some time. Enrolled patients with stage 1B to 3 lung cancer using the 7th edition, excluded patients with EGFR and ALK. They were randomized to a control arm of platinum doublet chemotherapy, which was histology specific for 3 cycles, or chemotherapy plus nivolumab for 3 cycles. And surgery was planned within 6 weeks of the last dose. There was no mandated postoperative treatment. However, the oncologist and patient could recommend some more adjuvant chemo or radiation, depending on the situation. And the primary endpoints were pathological complete response and event-free survival, both by blinded independent review. Do you see here what happened with the patients? So one potential benefit of neoadjuvant therapy is if more patients receive at least some systemic therapy. There was a study called The Alchemist in the US, which was a clinical trial where patients were enrolled and got chemo and then potentially adjuvant immunotherapy. But only 57% of patients in that study, even though they were fit, they had a stage indication for adjuvant chemo. Only 57% got any adjuvant chemo. So the neoadjuvant setting does increase the likelihood. So you'll see here 94% receiving or starting neoadjuvant treatment. You'll see one caveat with the neoadjuvant setting is that not all patients get to surgery. In the Nivo plus chemo arm here, it was 83%. In the other phase 3 trials, the ones I had on that previous slide, it also comes in about that 80% range. For more selected trials, I would say it goes up about, it goes up a bit. So there's a trial I'll mention later called NeoCOAST 2, and it's well over 90%. So I think it depends a little bit on your patient selection and the expertise at the centers involved in the trial. So we now have final overall survival for this trial 5 years later. And this shows a 10% improvement in overall survival, favoring those patients who got the 3 doses of nivolumab at the very start over chemotherapy alone at the very start. And you'll see this is a pretty persistent benefit. It starts about 15 months and continues out to 5 years. In terms of one potential criticism of trials like this is, do patients get the appropriate treatment at relapse? But one caveat with that as well is that some patients who relapse from cancer are not fit for treatment, or they may have situations where treatment is less effective for them. So in this case, in the control arm, 50% of patients got some form of immunotherapy at the time of relapse. And there were some patients crept into the trial who must have had EGFR and ALK alterations. So you'll see that here as well. 6 to 12% of patients were found to have EGFR and ALK. And this testing was only mandated in East Asia. So there were some patients probably who were in the study. But I think one benefit of neoadjuvant immunotherapy here for early stage lung cancer is that all patients get exposed to immunotherapy and have the potential to benefit from it. When we look at the subgroups within the trial, there was generally benefit across the subgroups. However, some groups derived more benefits. So you'll see here in the PD-L1 strata, PD-L1 positive tumors have a hazard ratio of 0.51 versus a hazard ratio of 0.89 for PD-L1 negative. By stage, very similar results for stage 3 and stage 2 disease. We've also looked at things like node positive versus node negative, and there appears to be very similar benefit between the two. However, one important thing to keep in mind is that, so when we're treating lung cancer, even earlier stage cancers, the patients have competing risks. And we see here that 10% of patients in both arms had died from non-lung cancer causes by 5 years. So when we're talking about any intensive therapy in early stage disease, I think we have to look at what other things may impact the patient's survival. There were a few interesting findings in terms of translational science or correlative analysis here. 24% of patients in the trial had a pathological complete response, so no viable tumor at the time of resection. And those patients who had that pathological complete response did very well. So 95% of them were alive at 5 years versus 56% in the patients who did not have a PCR. Another point to note is that among those patients with a PCR, death had occurred in 3, but none of those were due to lung cancer. We also looked at circulating tumor DNA, and this was over a 6-week period. So just prior to the very first dose of neoadjuvant therapy, and again 6 weeks later on cycle 3, day 1. So this is a kind of a very early snapshot of response to treatment. And we see here that those patients who had a ctDNA clearance during that very early period had 75% 5-year survival versus 50% in those patients without ctDNA clearance. And this analysis was limited because it was a tumor-informed assay, so you had to be able to sequence the pre-treatment tumor in order to create the panel, which when we're dealing with lung biopsies can be quite challenging. To talk a little bit about the surgery, so somewhat surprisingly, when we intensified the neoadjuvant treatment, patients actually had less aggressive surgeries in those arms. So you'll see here those patients who got nivo plus chemo had higher rates of lung-sparing surgery, lower rates of pneumonectomy. And so another surprising finding was that those patients did equally well in both groups, really. So those who had lobectomy had a 74% 5-year survival, pneumonectomy close to 80%. Now, having said that, these are relatively small numbers. So you'll see down the bottom, it's 25 patients in the nivo plus chemo arm who had a pneumonectomy. Right. Now, where do the patients who have a recurrence, where do those recurrences happen? And the interesting thing here is that the major impact of the immunotherapy is systemic. So you see a significant reduction in distant recurrence here in the middle, going from 22% in the chemo alone arm down to 10% in the chemo plus nivo arm. However, local regional recurrence within the chest is relatively similar. So this could be a potential avenue for future studies looking at adjunctive therapies such as radiation. Moving on to the key perioperative trial, the one that is the main competitor, I think, among these studies is Keynote 671. So this study was started a little bit after Checkmate 816, so it used the 8th edition of staging, included stage 2 to 3B disease, including N2, so slightly more locally advanced disease than Checkmate 816. And patients were randomized to a control arm of cisplatin-based chemotherapy plus placebo, or cisplatin-based chemo plus pembrolizumab. And patients had to be able to tolerate cisplatin to enroll. They then received up to 13 cycles of adjuvant pembro. And now we have long-term follow-up on this study as well. So here we see the event-free survival at 5 years is just about 50%, with benefit seen across subgroups. Again, though down the bottom, more benefit seen for those patients with PD-L1 positive disease. And so an interesting thing is when you compare the two studies, we're not supposed to do this on a routine basis, but looking at the survival curves, almost identical numbers in terms of 5-year event-free survival for both Keynote 671 and Checkmate 816 at 49%. And similar numbers for overall survival as well. So 65% for Keynote 671, 65% for Checkmate 816. So at least among these two studies and the early data from the other perioperative trials, they seem to deliver identical long-term outcomes. There are some studies out there which are trying to answer this question. Do you need adjuvant treatment after neoadjuvant chemoimmunotherapy? This is one which we have active in Ireland and also active, I believe, in the UK, called Adopt Lung. This enrolls patients with treatment-naive stage 2B to 3B lung cancers. They all receive chemotherapy plus durvalumab up front. And then among those patients the key analysis is among those patients who don't have a PCR, and they're randomized to either durvalumab or observation. And the goal here is to evaluate the benefit of adjuvant durvalumab among those higher risk patients. We've also looked at intensifying the neoadjuvant phase, and this is the study I mentioned earlier, which is called NeoCOAST-2. It's active globally at the moment, and this study essentially aims to add on to neoadjuvant chemo plus PD-L1. All 6 of the arms you'll see here have now enrolled patients. Several have been reported. I'll show you some of the data from them. This was a paper published just earlier this year, in which we found that, and the interesting finding that the antibody drug conjugate, so datopotamab deruxtecan, which is a Trop-2 ADC, when that's added to neoadjuvant chemotherapy plus durvalumab, it does significantly increase the pathological complete response rate from what you might expect. So it goes up to about 35%. And the benefit seems to be seen across PD-L1 strata. So a signal from this study, I think one thing we have to be careful with here is the rate of surgeries. And despite the intensification of the neoadjuvant treatment, still more than 90% of patients have a curative surgery in this trial. So where do we stand at the moment? So neoadjuvant chemotherapy plus PD-1 pathway blockade does deliver a significant clinical benefit for patients who have a good performance status without significant competing risks. And there's relatively modest additional toxicity compared to chemotherapy alone. You do have to deal with the chemotoxicity, obviously. ctDNA and pathological response are potentially dynamic biomarkers of benefit, and I think this is being explored in other studies. And it's a multidisciplinary platform. I think, as you know yourself, when you have to evaluate these patients for neoadjuvant therapy, there's a lot of people involved in terms of molecular testing, getting patients in to see medical oncologists, getting patients started on treatment. And as yet, the added benefit of adjuvant anti-PD-1 after neoadjuvant chemoimmunotherapy is not clear, and there are studies ongoing which are trying to evaluate this. So thank you.
Thank you very much, Professor Forde. Please do post questions in the Q&A. I don't have any questions at the moment, so I'm going to kick off. A very interesting talk, and it's clearly completely changed the landscape of what we do now in terms of thoracic surgery and in terms of the pathway. I'm interested to hear how you would manage the optimal pathway for these patients now, because there's a lot of controversy over the delays to repeated biopsy, need to obtain molecular testing, delays in molecular testing. What are your thoughts on that?
Yeah, so it's definitely an issue. I would say probably 10 to 20% of patients, we have challenges getting the molecular testing done due to insufficient biopsies. I think, so it's always a balance, you're probably going to be more keen to do kind of rebiopsy and retesting for a patient with stage 3 disease, I think, than say someone who's got a 4-centimeter tumor that's node negative. But on the other hand, I think as medical oncologists, at least, we feel that most of the benefit from immunotherapy in kind of early stage disease comes in that neoadjuvant period. So when I'm talking to a patient, I'm kind of saying to them, so obviously it's a balance between getting you to your surgery, getting you cured. But then the problem is if you come back to me post-operatively and you have say an occult node positive and you're PD-L1 negative, we really don't know what the benefit is going to be for you, from giving you a full year of immunotherapy. So we do try and expedite it. A lot of the time, I think it helps if there's kind of an all hands on deck type approach, trying to work with pathology closely and being as clear as possible at the start as to how much tissue is available and will the NGS come back. There are some moves to use liquid biopsies, and some of these trials I mentioned permit use of liquid biopsies, for example, for EGFR. I think that's going to be more helpful in stage 3 than stage 2. So it won't solve the problem, but it is kind of spreading awareness that this is a changed paradigm.
Absolutely. Okay, so first question. Do you think that you talked about intensifying the neoadjuvant phase? Do you think that 4 courses of neoadjuvant immunotherapy is too much?
Well, I think there are a few studies on that. There was a Chinese trial where they looked at 2 versus 3 versus 4, and 3 seems to be the sweet spot. So I think if you can get 3 or 4, that's probably enough. But there are some patients you'll run into issues with. Actually, what I found here in Dublin is most of the issues tend to be with the chemo, not with the immunotherapy part of things. So sometimes I'll drop the chemo for cycle 3 and 4 and just give the immunotherapy for those 2 cycles. But the Chinese trial suggested that 3 was more or less equivalent to 4, but 2, there may be some slight decrement in the amount of treatment or in the efficacy.
Okay. And what about earlier stage disease? So there's often this debate of whether or not amongst the surgical community, these patients are doing so well, should we be extending this neoadjuvant to earlier stage 1 disease?
Yeah, I think that's something like, for example, the breast cancer community, they look at kind of an 80% 5-year survival, and they see that as being very poor. I suppose in stage 1 we see 85% survivals, and we think it's good, but it's all relative. And I think one of the other arguments is when you look at, so there are people advocating that if you have 90% survival with a PCR, you should still be looking to increase that. So I do think we should be looking at stage 1. I think the challenge is it would be easier to give adjuvant therapy to stage 1 than to give neoadjuvant. But as I said earlier, most of the benefit appears to be neoadjuvant. There is one study which one of the pharmaceutical sponsors is running with the goal of giving neoadjuvant immunotherapy to stage 1 disease, and that study is going to be a long trial. I think the readout won't be for 8 or 9 years. But I do think it's something we should look at, because these patients do have relapse, and as we saw in the trial, not all patients who have relapse get the opportunity to have immunotherapy at the time of relapse.
Absolutely. In terms of node disease, the next question is about nodal disease. Do you think we all, in terms of the N0 patients versus the N1 versus the N2 subgroups, are we correct in giving immunotherapy to those patients who have N0 disease, who've got borderline size criteria for neoadjuvant therapies?
Yeah, well, I think the thing to keep in mind is that the size criteria was really developed from the studies from the chemotherapy era. So we don't know that 4 centimeters is like the perfect cutoff for chemoimmunotherapy or for immunotherapy even. And I think most of the analysis have suggested equivalent hazard ratio. So the one from Checkmate 816 showed a hazard ratio for event-free survival of 0.72 in the node positive, 0.71 in the node negative. Now, node negative, so is a broad category. Some of those tumors might have been quite big. They could have been invading chest wall and things like that. But I do think there is benefit. So I think we don't really select. The first, say 6 months or so when I moved back to Ireland, we were treating predominantly stage 3, but I think we are now, there's kind of an open approach. So among our group, that anyone who has an indication for systemic therapy should be considered for neoadjuvant therapy. And it does make it easier, I think, for patients, particularly. So we serve an area going from the north of the country down to the very far south, and 3 cycles of treatment as opposed to a year of therapy can be quite attractive for them as well,
Yeah. For sure. One of the questions that we're having in our MDT at the moment, and clearly we're still resecting them at this stage, but we are seeing excellent rates of PathCR now. Do you think we're going to get to a point where these patients don't have surgery because they are having such excellent responses? And are we putting them through harm by operating on them in the first place?
I think it's a really difficult one. We've had a few patients with pneumonectomies after, and then they turn out to have a PathCR, so it's a difficult one. It's just we don't have a good way of judging it. We can probably tell to some degree which patients don't have a PathCR. So if you have persistent ctDNA, for example, you're very unlikely to have a PCR. If you have persistent FTG ability, it's less likely you'll have a PathCR. But none of the studies really have shown clearly which patients. So you can clear your ctDNA but still not have a PathCR, and I think it's difficult to leave those cancers behind. I think situations where there's a really high risk to the patient. So, for example, invasion of the atrium or something like that, where the patient seems to have had a really nice response. Those are the sort of ones where you have to individualize it and kind of make a decision. Is this really in the best interest to go and do this really potentially risky surgery?
I think also that feeds on to the next question in terms of the fact that, as you said in your talk, that recurrence tends to be local regional rather than systemic. And in fact, even in those patients with PathCR, perhaps we do still need to be resecting those. What do you think about the dormancy pattern of disease recurrence? And
and it's kind of the opposite. So if you look back at the 5 chemo trials, the five adjuvant trials, about 70-80% of the recurrences in those trials was distant, so it was outside the chest. But I think what's happening is we're bringing down the distant recurrences, but we're not having as much of an impact on the local recurrences. And I think it is challenging when you still have a persistent N2, for example. So we had the lung arc trial, which suggested in the chemo era that there wasn't a benefit from adjuvant radiation. But there are some efforts I know among radiation oncologists to reevaluate that now that we have a different paradigm for treating patients.
for sure. And potentially integrating radiotherapy with the neoadjuvant phase of immunotherapy and sensitization. What are your thoughts on that?
So Dr. Al Torki, who's based in New York, had a study of this subablative radiation concurrent with chemo and immunotherapy. So it's interesting, I think, that the problem is some of the studies in stage 3 disease with standard dose radiation combined with immunotherapy have not been encouraging. So I think that's lessened enthusiasm a little bit for that approach. And the stage 1, so where patients were getting a stereotactic plus immunotherapy for stage 1 disease, those studies were negative as well. So I'm not sure if it's going to proceed to a full phase 3 trial, but it's an interesting finding that some patients may benefit from that.
Time for a couple more questions. First, the next one is, do you think that patients who've had pathological complete response should then have adjuvant immunotherapy, and what would be your practice?
So I have a low threshold for those patients not to give further treatment. I think there is some risk for them. The risk of a really serious adverse event from adjuvant immunotherapy is low. So depending on the study, it's between 0.5 and 0.9%. But if you treat everyone in a country, so in Ireland, we've about 400 lung cancers resected, and that would mean you'd have probably about 3 or 4 patients a year who would die from the adjuvant immunotherapy. So I think you have to look at it. And then if we look at the PCR rates, no patient who had a PCR in CheckMate 816 died from lung cancer. 3 of them died from other causes. And in Keynote 671, they didn't have really kind of mature follow-up, but less than 10% of patients had a relapse of cancer with PCR. So I think you have to talk to the patient and kind of see how they feel about it, say there is some risk, and there is obviously an impact on their lives. But for most patients, I don't tend to offer adjuvant immunotherapy if they have a PCR.
Excellent. We've reached the, I think we could go on forever. Unfortunately, I think we have reached the time limit. So I am going to conclude here, but thank you so much for a really excellent presentation, for a very, very clear overview of the data, and for taking the time to speak to us and answer everyone's questions today. Thank you very much, Professor Forde.
No problem. Thank you very much for the invitation. Take care.
Yeah, bye-bye.